Welcome to this series of interviews with the giants of cardiac surgery. My name's Joel Dunning and I'm here at the EACTS conference in Geneva with Professor Ralph Damiano. Ralph, you were trained by Jim Cox. You then became Professor and Chief of Cardiac Surgery at Washington University at the Barnes-Jewish. You're President of the Society of Clinical Surgery and current President of ISMICS, having done the first robotic grafts in North America. You're Associate Editor of JCTVS, but what I'd like to talk to you today about is the Cox-Maze 4 procedure, a procedure that you're absolutely key in creating. What I want to do for the viewers of CTSNet is actually go through it step by step with yourself and perhaps help our viewers with some of the more difficult steps. So if we may maybe assume that first of all you're in your clinic, you're with a 45-year-old or 50-year-old gentleman. He has really symptomatic permanent AF. He's come to you, his angiogram's normal, his LV's fine, he doesn't have any valvular problems, but his left atrium's maybe 6-7 centimetres and the electrophysiologist's really not happy just doing pulmonary vein isolation. First of all, what would you say to him and what tests would you like before you took him to theatre, for example?
Yeah, well, that's an excellent patient and quite representative of the type of patients that are referred to surgery. I would say in this day and age, even in that type of patient, we'll often see them after one or two attempted catheter ablations, but not always. And the results in patients with atrial sizes of over 4 centimeters and long-standing persistent atrial fibrillation, a patient like you described, the results with catheter ablation have been relatively dismal in almost every lab, and even with multiple ablations, success rates still hover in many instances just right around 50%. So this is a good candidate for surgical ablation procedure, and certainly with a full Cox-Maze lesion set, even with an atrial size of 6 to 7 centimeters, our success rates are still between 80 and 90%.
I know we have our routine tests, angiography and Holter monitoring, and I'm sure you want them to go through the full attempts of medical management, but I understand you've got some new investigations to help you with your decision making.
Yeah, so first of all, in terms of routine tests of someone referred like this, and I think the first thing we really would, in any patient in their 40s, certainly in the U.S., we really mandatorily get an echocardiogram, if it hasn't already been done, to rule out any valvular heart disease, to get an adequate measure of left atrial volume. And also, it's really important in a patient with persistent atrial fibrillation, particularly if you don't have excellent records about their anticoagulation status, to make sure there's no clot in the left atrial appendage. If that is any issue, a lot of times we'll get a transesophageal echocardiogram pre-operatively. I should mention to the viewers is if a patient is referred to you after a failed catheter ablation, there's a couple different tests you probably will want to get. And the first test is an imaging of the pulmonary veins. Pulmonary vein stenosis is a rare but described complication of catheter ablation. You certainly would want to know that going in, and you certainly wouldn't want to be blamed for it after your own procedure. So we would usually either get CT scan, pulmonary vein protocol, to get good feel for the pulmonary vein anatomy and whether there's been any problem, or MRI is adequate. We do not find echocardiography alone to be adequate to assess the pulmonary veins and any potential post-ablation issues. Another more recent test, and I should admit that this test is still experimental. We've done a lot of work with it at Washington University, and that's ECG imaging. I think over the next decade, this might, as it becomes more clinically available, have a big impact on certainly decision making on what may be the best clinical strategy in these patients. Now, ECG imaging has been in development for really almost 2 decades by Dr. Yoram Rudy, who's a professor of biomedical engineering at Washington University. And it's a unique test in that you put the patient into a CT scanner and then place a jacket of electrodes, basically similar to a dinner jacket, if you will, but imagine one that's embedded with 200 to 300 different electrodes. you record the electrical potentials from the body surface at the same time you're scanning the patient, so that you can get precise measurements of how far the skin is from the heart and what are the structures in between. And then by solving the inverse problem, which is really how do you predict what's happening on the heart from the body surface, you can actually draw quite detailed activation maps of atrial fibrillation. We have a paper in press right now in circulation which shows the accuracy of this technique in determining a focal source is plus or minus 6 millimeters, which we verified by atrial pacing in the electrophysiology laboratory. But it also helps to try to identify the mechanism. That said, we've now studied almost 40 patients and have found that in the majority of patients there's multiple wavelets that seem to be driving atrial fibrillation. In probably 70% those drivers are often from the pulmonary veins, but in about 60% of patients there was non-pulmonary vein drivers of their atrial fibrillation.
So to surgeons that say I'm just going to get in there and bang off a left-sided maze because Hassegair says they're all from pulmonary veins, this isn't the case.
No, it's absolutely not the case, and more recent work has shown that probably only about two-thirds of the triggers in paroxysmal atrial fibrillation are from the pulmonary veins, which means that a third are not. And things that make you more likely to have non-pulmonary vein triggers are a left atrium greater than 4 centimeters, just like this patient, women, and certainly the presence of organic heart disease, which is often what we see in surgery. In our own mapping, where we've done epicardial mapping, we find that approximately anywhere from 20 up to 30% of the time, we can identify, at least at times, drivers in patients from the right atrium. So it's a myth that atrial fibrillation is left atrial disease only, in fact. And in particular patients with long-standing atrial fibrillation, there are patients where right atrial sources play an important role in the maintenance of atrial fibrillation. And not only our group, but others have shown that in mapping studies. So it's important not to get led down the garden path by that one report from Hassegair. And it's really, and certainly in organic heart disease, doing only pulmonary vein isolation, in my opinion, is almost never indicated. But ECG imaging will be, when it's available, I think an excellent test, because what it does is it allows surgeons to be able to define a mechanism in an awake patient, and then and in a very non-invasive way. So you do not require a trip to the electrophysiology laboratory, and the whole study takes approximately 10 minutes. It also is a good way to image the pulmonary veins. You can get a 2-for-1, which we often do when we perform ECG imaging. In many ways, it will be like CT angiography if it gets really quite accurate, that could replace invasive cardiac catheterization, and this might be the electrophysiologic equivalent. I think it has a lot of promise. We're looking at it. Now, I should say as a proviso, and the one thing that you have to realize, in about half the patients, the mechanism of atrial fibrillation changes over time. That is, if you map them long enough, what starts to look like a left atrial focus, let's say, from one of the pulmonary veins, will often migrate into the posterior left atrium and even sometimes the right side. So, we're going to have to carefully verify the accuracy of the test, but it certainly has a great promise to direct therapy, and certainly maybe allow us to triage patients to a single left atrial lesion set versus the traditional biatrial lesion set of the maze.
But as we are today, a simple left atrial maze is not to be taken lightly, really, even concomitant.
Yeah, we don't usually do it. It's about 10-to-1 in our present practice of biatrial versus just left atrial. And while we're talking about it, I think, it takes, with present ablation devices, to do the right atrial lesion set is quick and can be done in 10 to 15 minutes. We do it really, when we do a minimally invasive right mini thoracotomy approach, we do it all through purse strings, so we never even open the right atrium. Through a sternotomy, and we can talk about that, we usually make a single right atriotomy, but it's actually quite a quick and easy procedure. Since we usually don't know preoperatively exactly where it's coming from, we usually recommend biatrial, though there can be exceptions to that.
Yeah. So I'd really like to go through step by step the sort of the Cox Maze 4, because I think that would be very useful. So are there any special things you want from your anaesthetist just before we go in, or fairly routine?
Well, a couple things if you're going in for lone AFib surgery, that is a combination of the anesthetist and your perfusionist if you're doing a maze, full maze lesion set. And first of all, we usually have the anesthetist give a bolus of amiodarone, unless the patient has had major side effect from that drug, right after induction, so we have reasonable levels, because we will want to cardiovert the patient early in the case to make sure we can obtain pacing thresholds from all 4 pulmonary veins. We also will tell the perfusionist that when we go on bypass, one thing you do not want to do is cool at all, so we actively maintain body temperature at about 36 degrees to be able to cardiovert the patient out of AFib if necessary.
So we better get on to the operation. You're placing your aortic and bicaval venous cannula. Do you have any good tips of exactly where to put the biatrial venous cannula so you can get good access?
Yeah, and if you're going to be doing a standard maze operation, which is a biatrial procedure, you want to, the aortic cannulation is not anything special. You don't need to cannulate up high on the aorta because you really are going to be doing no manipulation except for cross-clamping. In terms of your caval cannulation, if you're through a sternotomy, we usually recommend putting the SVC cannula up just onto the superior vena cava. And the IVC cannula, we usually recommend placing it away from the surgeon, if you will, more medial as opposed to lateral. The lateral border of the inferior vena cava, you want to leave enough room to get the ablation clamp down into the inferior vena cava, and it helps if you have your IVC cannula more medial, that is, toward your assistant side of the table.
So we've gone on bypass, we've commenced the bypass, and we're keeping warm, and I understand you check pacing thresholds quite extensively first of all.
Yeah.
I wanted to sort of know about that, and what if you can't convert them out of AF? What do you do?
Well, that's an excellent question. So first of all, the first things we do, and we do not cardiovert them immediately in the beginning of the case, because you really want to dissect bluntly out the right and left pulmonary veins, and also dissect Waterston's groove, and try to remove as much of the fat from Waterston's groove as you can. Usually in the process of this dissection, you'll often put patients in AFib. This patient, though, that we're talking about is in persistent AFib, so we'll just assume he is. But we would want to bluntly mobilize the right and left pulmonary veins, and we usually put umbilical tape, but you can put red rubber or anything you want around it that helps to push the clamp down underneath it. After we do that, we would then cardiovert the patient. I would say, right now we've done almost 600 cases, and in those cases, it is unusual not to be able to cardiovert them. A couple, we've had probably, between 5 and 10 patients we've been unable to cardiovert. Those are often patients, it's extremely rare in a lone AFib patient, but is not unusual, let's say, in someone with rheumatic heart disease and a really enormous left atrium. The other groups of patients which we can't cardiovert, which if you have a left atrial thrombus, and it's extremely dangerous, and I would say don't do it. And in that situation, we either don't check thresholds and will have faith that our bipolar clamps will work, and they've been the recent generation clamps, I think, are extremely reliable, certainly if you do 2 or 3 ablations on each side. And most of our experience has been with the AtriCure Synergy clamp and the recent generation Medtronic CardioBlate low-profile clamp. And both of those with 2 or 3 ablations are well up over 99% effective. So I would say then you're left with doing more blind pulmonary vein isolation. But I would tell to surgeons, in the great majority of the time, you can cardiovert, and it is a nice, and I think a very important test of the efficacy of your ablation. It's also a nice way to make sure your ablation devices are working appropriately.
And so moving on to this sort of bipolar ablation of the pulmonary veins, first of all, I suppose, how many times do you clamp and ablate? Presumably you're meticulously checking every time. And is there a rule, or can some people just do it twice and leave it at that?
Yeah, I think that's a lot of people ask us that. We've done a lot of animal work, and we did the initial animal work on both of the bipolar clamps, and that I've mentioned, and certainly in animals, even with one clamp, they really approach 100% reliability. We did not find that early in our experience in people. I would say with the present generation, after 2 ablations, where we always routinely check, they're both above 95% effective, but they're not at 100%. And I think it's really a shame if you leave the operating room and haven't isolated the pulmonary veins. We know that clearly will predict failure in patients. So, I still recommend checking, and I still think it's very important. I know surgeons that do 5 or 6 ablations and don't check. Is that always adequate? Generally, it will be. But I think, for a couple reasons, I think it's a very important endpoint, and certainly the endpoint that's accepted by the electrophysiology community. And I think an important thing to show your referring cardiologist and electrophysiologist that you are taking the actual operation seriously.
And you check the superior and the inferior vein, not just one.
Yes, and it's not unusual to have one isolated and the other conduct. So, it's important to remember that the muscle sleeves around the pulmonary veins are not uniform. They don't, even in a normal person, always pace from every area. So you have to first determine where you can capture the pulmonary veins, and then go back and check in. Often we'll check the superior, the inferior, and also in the crux between the two as a quick, and it can be done very quickly.
What about all those terrible ganglionic plexi? You must be obsessively fixing them, eh?
Well, that's an interesting and controversial topic, but certainly in St. Louis, we do not believe the ganglionic plexi should be ablated. There's no question that they play a role in the pathogenesis of atrial fibrillation. The problem is that in the normal human, there's between 400 and 600 ganglionic plexi. 2/3 of them are in the right atrium, and 1/3 are in the left atrium. They are ubiquitous. They do cluster in fat pads, but the problem is if you don't totally denervate the heart, partial denervation has been shown both in animals and humans to be very proarrhythmic. That's one problem. The second problem is that in almost every study that's looked at it, including one we've just published using present devices and the present surgical technique for ganglion ablation, you get reinnervation usually within between 1 and 3 months. And in a canine model, we showed reinnervation after GP ablation as early as a month. The problem is it's not uniform reinnervation. So I would tell all surgeons that it's really not worthwhile doing it. Takes some time. You might as well focus on doing the actual maze procedure correctly. And there's really been to date, even though they were introduced between 5 and 8 years ago, there's no convincing clinical evidence either from the electrophysiology laboratory or the operating room that it serves any purpose.
So let's move on to the incisions and the further ablations you make on the right side. How do you proceed from there?
So, and if we talk through a sternotomy, the first thing we do is take a purse string suture at the base of the right atrial appendage. The right atrial appendage is preserved in the maze 4 for a couple reasons. There's less fluid retention if you don't amputate both atrial appendages, and also it does, in about 5% of patients will need a pacemaker and who have long-standing persistent AFib, usually due to the sick sinus syndrome that preceded their actual going into atrial fibrillation. And it's nice to have an atrial appendage. Your cardiologist will be very happy that you left it. But we take a purse string suture in the base. We then take a bipolar clamp and make a right atrial free wall ablation. This is an ablation that extends down toward the superior vena cava. And the important thing is when you create your ablation lines on the right atrium, to make sure there's approximately 2 centimeters of distance between all the ablation lines. So people ask me, how do you decide where to put that? And I try to make it so it's 2 centimeters above where I think the SVC ablation will be with a bipolar clamp, and about 2 centimeters superior to where we make the right atriotomy, or if we're through a minimally invasive case where we make the right atrial free wall lesion. So this first lesion goes down and onto the right atrial free wall toward the superior vena cava. Next, and we'll make it simple in how we've described it initially, a small right atriotomy is made. You extend that. Again, you take it 2 centimeters, move down 2 centimeters from your ablation line you just created, and make a vertical right atriotomy extending from the intraatrial septum and up toward the atrioventricular groove, approximately the free margin of the heart. If you aim for the free margin of the right ventricle, that's a very good place you want to be. It's important on that atriotomy, we divide the crista terminalis, which is a big preferential conduction pathway. And that's because that has been shown actually to be quite an important pathway in many atrial flutters, especially some atypical atrial flutters. And also it's extremely thick, and it's about the one chance you're going to have, often over a centimeter thick. Very hard to ablate in any other way, very hard for the EPs to come back and ablate it. So we do divide that. We then, through the right atriotomy, from the inferior aspect of the right atriotomy, we take a bipolar clamp and we go down into the inferior vena cava. And then we rotate that clamp and take it superiorly up into the superior vena cava. Again, staying laterally and as inferior as possible. You want to avoid the area of the SA node, which is actually quite a diffuse and mobile structure, which sits right at the, traditionally it's been shown to sit right at the junction of the superior vena cava and right atrium, but it's often more superior. But recent work we've done in mapping human sinoatrial nodes have shown that not only is it incredibly diffuse, but with different autonomic tone, the sinoatrial node can migrate all the way from its traditional histologic place, almost down along the crista terminalis down toward the IVC. So we try to avoid that area for ablation. While we're doing that bipolar clamp, we usually take a linear cryoprobe from the superior aspect of the right atriotomy and endocardially create a lesion down to the tricuspid annulus at the 2 o'clock position. Now that, we use a linear reusable cryoprobe that's presently distributed by AtriCure, but was developed by the old Frigitronics and then Cooper Medical. It's a very nice reusable device. It uses nitrous oxide. It's very, very cost effective if you have one. And during that ablation, which you usually perform for 2 minutes, your assistant can hold the cryoprobe while you're finishing the bipolar ablation. So it's a time efficient also.
And that's better than an ablation pen or something like
Well,
that.
we find it it's much less prone to surgeon error. To get all the way to the tricuspid annulus, you can get almost down there with the bipolar clamp, but because of the atrioventricular groove in the right coronary that sits in there, it's almost impossible to dissect all the way down. If you
Because you did sort of recommend sort of
Right, and then
dissecting it, but is
in
that
the
just
initial-
getting a bit scary?
Yeah, you're exactly right. Our initial publication shows that. And when we first introduced the bipolar clamps, there was a feeling that somehow we had to try to use them for everything. In teaching a lot of surgeons how to do the Mays procedure, we found most surgeons very uncomfortable with that dissection. And the nice thing about cryo, or it's perfectly appropriate to use one of the linear pens that are available, or any unipolar source of energy, that tends to be a little easier from a surgical standpoint. We find the cryo to be the easiest, but certainly if you use the pens appropriately and by the manufacturer's recommendation, we've found that they have worked equally as well. We've done probably between 40 and 50 patients with the instead of cryo using those unipolar pens and have found the results to be identical.
In terms of transmurality, you can't check these, can you? You've just got to
No.
trust them, really. Have you?
And that's where, I think, and that's an excellent point, is that except for the pulmonary vein isolation, we can't check the lesion integrity of any of these lesions. We know from experimental work that certainly the clamps are very close to 100% transmural in animals, even with thicknesses of up to a centimeter and above. And so we feel very comfortable that probably the most reliable of all the energy sources are these clamps. But you're right, when we use the unipolar, it's really not possible to check. Now, the nice thing about cryo, if you apply it on the endocardial surface, as we do, you can see when the ice ball comes through to the epicardial surface. And that's a good indication. Once you see that, if you freeze for another 20 to 30 seconds after you see the ice ball, certainly there's some good evidence, much of it still unpublished, that is a good indicator that you're transmural. Right. The ice ball usually occurs between around minus 10 degrees centigrade. That's not the temperature that cells die, but it's a good indication you're getting very close.
Okay, great. Well, I think we've addressed the right side, so it's time to give cardioplegia and cross clamp. So
now, I would say when you're doing a lone maze, that it's not necessary to use retrograde. It's a short cross clamp time. Our average cross clamp time is now about 30 minutes. We usually give one dose of antegrade. It's important that if you do decide to use retrograde, and maybe you're early in your experience and you're uncomfortable, you may have a longer clamp time, that before we close the right atriotomy and go ahead with the left atrial ablation, since we have the right atrium open, we put the coronary sinus catheter in under direct vision, put a U-stitch at the mouth of the coronary sinus, come down with a purse string on that U-stitch and pull your coronary sinus catheter back right to the os of the coronary sinus. Because it will be really important now that when you try to ablate the left atrial isthmus, which is one of the, I think, the Achilles heel of the maze procedure, if you don't do it well, you'll see a number of patients have recurrent, particularly late left atrial flutter. And you have to remember the coronary sinus is very conductive of atrial impulses. In many ways, it's a contiguous part of the left atrium. So you really need to be able to ablate full thickness. And if you have a cardioplegic cannula in over where you're going to ablate the coronary sinus, you may not penetrate completely, certainly with the bipolar clamps. So we are pretty compulsive about making sure that's pulled back all the way so that we have a pretty much big area of the coronary sinus that we can ablate. And one last thing we also do before we cross clamp, which I should mention, is that we know from the preoperative cart catheterization if the patient's right or left dominant. They're almost always, even in a left dominant circulation, an area of the coronary sinus in which there are no coronary arteries in the vicinity. So we pick up, look, and mark the coronary sinus with methylene blue, just a little bit of methylene blue, before we go ahead with the left atrial lesion set. And that's simply to avoid either freezing or clamping a coronary artery. Neither a bipolar ablation, which we've shown in animals, or cryo will actually result in acute coronary occlusion. But both have been shown in animal studies to lead to intimal hyperplasia and could lead to late coronary stenosis. So we really recommend that surgeons avoid any ablation in the vicinity of coronary arteries.
And that is the one lesion that people are quite anxious about, isn't it? That
yes.
Onto the mitral. And you can't just leave it then.
Yeah, you cannot leave it. And this is a simple way, and I think, particularly if you get used to doing this in open cases, you will develop a feel for just by looking at the angiogram where that space is going to be. So when we do the minimally invasive right mini thoracotomy, at this point we know that if it's a right dominant system, you can pretty much aim for the midpoint of P2 and you'll be completely safe. If it's left dominant, as long as it doesn't hug the coronary sinus the whole way, which it's very unusual that it does, if it comes out of the AV groove, we usually try to aim as close to the posterior commissure as we can get. So that would be well on to P3 as a landmark. And if you follow that recommendations, you will be very, very safe 99.99% of the time.
Yeah, and just about the left atriotomy, you extend it quite far around the inferior veins, don't you?
Well, we've kind of gotten away from that, but I will tell you it's what we would consider a standard left atriotomy for mitral surgery. We do take it, which some people might not do, but I've gone to doing this in the mitral valves because it gives you nice exposure. Superiorly, you need to just take it up to the beginning of the dome of the left atrium, right up to where the left atrium usually comes underneath the SVC. On the other side, we usually do hug and come just around the right inferior pulmonary vein and then stop it at that point. We don't take any of the incision across the back of the left atrium unless we're doing an atrial reduction, which is a whole other topic we could get into.
Yeah.
But I think standard, that's what we do. And certainly in an atrium that's 6 to 7 centimeters, the clamps are absolutely long enough to reach into the left pulmonary veins.
So just, I suppose you brought up left atrial reduction, so at 6-7 centimetres of the left atrial size, would you reduce a little, or really this is
Well, that's
10
quite
centimetre ones?
controversial, and we recently presented it at the ATS this year, our data on our full MACE 4 experience, and one of the, atrial size remains a major risk factor for failure. Where it begins to fail dramatically is at 8 centimeters. But there's no question that from 6 to 8 centimeters, you're seeing higher failure rates. Our traditional approach in St. Louis has been that if it's 7 centimeters and up, we've done an atrial reduction. If it's below 7 centimeters, we haven't. With our recent data, we're thinking of maybe whether we should take that down to 6 centimeters. It still remains a very, I think, open question, since we've never done a randomized trial in this area. Is large left atrium just a marker of a bad atrial myopathy, and that even if you reduce it, you'll still have a high incidence of failure? Or is it the actual atrial dimension? And I think that remains unclear. There's certainly patients with rheumatic disease where you see a lot of atrial wall fibrosis, and probably the atrial reduction won't help you. But in a patient who has relatively normal atrial tissue, I think the reduction is important. You have to remember that, especially in a concomitant patient, if you're fixing the mitral pathology, you're going to, over time, get atrial reduction. But if we did do that, we're probably still around 7 centimeters, though I think we have data now to say that we probably need to drop to 6. This is where some surgeons will start to feel uncomfortable, and there's lots of different ways to do atrial reduction. But how we like to do it, and I think it's pretty simple, is just extend your left atriotomy down across the floor of the left atrium, down toward, but not all the way to the AV groove. Some surgeons recommend taking it down to just around the orifice, the left inferior vein, and then just close it. I don't usually close it with plication. I usually don't recommend, unless you really have very pliable and good quality atrial tissue, to excise a big strip of posterior left atrium, because if you go too far and there's any tension back there, it's a really tough place to stop bleeding. But if you just make an incision back there and then just take really big bites with your purling suture as you close, you'll get a very good atrial reduction.
Okay, so just finishing off the left-sided lesions, you've still got to open up the left atrium and do a few lesions there, haven't you, to finish off?
Yeah, and I would say so let's start from the beginning of that. So we would cross clamp. The first thing we do is to retract the heart, expose the left atrial appendage. Now, our present practice, and it's the most cost-effective, and various studies, and Joel, I know you're an expert on the appendage and could review that literature much better than me, but certainly the most effective way of all the different proposed ways of managing the appendage has been surgical excision, and that's our method of choice, certainly through a sternotomy, where it's very easy to do. It's the most effective and the most cost-effective also. So we would take the appendage off. Through the open appendage, we take the bipolar clamp and extend an ablation in to one of the pulmonary veins. It doesn't matter. And make sure that ablation line crosses the ablation line you previously made to isolate the pulmonary veins. And then just close the left atrial appendage. We usually close it in 2 layers with a running 4-proline. I would usually recommend that the first stitch, as you anchor that first mattress suture, we usually use pledgets, because as all surgeons know, a tear back there is very bad. And that's one of the things after you do that, to make sure you check right before you come off, because there's often little tiny bleeders. Some surgeons will coagulate the whole edge, the cut edge of the appendage, because there's often little arterial bleeders in that edge. Once we finish that, we put the heart back in its anatomic position, make our atriotomy as I described. We won't talk about an atrial reduction, but a standard one. And then using your standard retraction like you would for a mitral valve, expose the mitral and the posterior left atrium. For surgeons who aren't used, who a lot of surgeons will say, well, I like transeptal exposure. It's really not a good idea for this. And one trick, if you're doing a lone maze, that's quite easy, is use a handheld mitral retractor and slip the handheld retractor into the mitral annulus, and then have your assistant just gently pull it up. It pulls the whole posterior left atrium to you. And all you really need to see for a maze is the edge of the posterior annulus. You don't need to really, you're not going to be doing a mitral procedure, so you don't need, the exposure even in small atrium is always adequate to do it. Once you expose that, we usually take a drop sucker and let it go into the left inferior vein. If you use a drop sucker, it almost always falls into the left inferior vein, so it's a nice marker of where your first ablation will go. From the inferior aspect of left atriotomy, we'll take the bipolar clamp, take it across the back of the left atrium, and place it into the left inferior pulmonary vein. Often with both the ablation devices we've used clinically, it's sometimes very hard to see where your left pulmonary vein isolation, the circumferential lesion is. Occasionally you can see it and you can make sure your clamp crosses it, but generally if you get into the mouth of the left inferior vein, you'll always have crossed the ablation because you're ablating up on the cuff of left atrium. We usually do those ablations. Every ablation in the left atrium we perform twice. Again, since we can't test it, we want to make sure we've had a good ablation. So it's important to remember, if you're using dry bipolar radiofrequency energy, that after every 2 ablations we assiduously clean the clamp. Any char on the clamp will cause the energy not to be adequately passed to the tissue, but you will continue to get the algorithms which look at resistance, changes in resistance, to tell you you've got transmural lesions. So it fools the algorithm with dry bipolar, absolutely. So it's really important. We found in the lab, and it's absolutely true clinically. If you get any char, and that's a common mistake people make. Once those, even after a single ablation, if you see a lot of char, you probably need to remove it and take it. For the irrigated devices, you don't need to bother cleaning it because they don't char because of the irrigation. So we take the inferior, then we take the clamp out, clean it, and then pass it from the superior atriotomy, one jaw inside, one jaw outside, into the transverse sinus, across the dome of the left atrium, and just guide that inferior jaw into the left superior pulmonary vein. That then completes a box isolation of the whole posterior left atrium. And in a work we published in JTCVS a couple years ago, we found that just that extra ablation, where you isolate the entire posterior left atrium, increased our success rates at 6 and 12 months by 20% when you looked at drug-free success. So it's very important, we feel, both in lone and concomitants, to isolate the whole back of the left atrium.
Do you actually check that once the pleasure's off and the heart's
Well,
beating again?
it would be nice to do that, but it's almost impossible. And, you know, if you have an electrophysiologist that you can talk to, twist their arm to come in and help you, you could probably do that, but generally we do not. Because it's very hard, unless you have one-to-one AV conduction, which is unusual after cardioplegia, it can be hard to demonstrate that. The times we've looked at it, we probably early in our experience in 10 or 15 cases looked at that, and you know, it seemed to always have been isolated. But again, it's often hard to tell without a little bit more sophisticated mapping system.
So I think we've completed our left-sided lesion set. So
no, we're still missing one.
Oh,
the left atrial isthmus, or the line that everyone does feel uncomfortable with, including in our interview. Down to the mitral annulus. So the last thing you'll do is, after doing 2 ablations up on the superior, into the left superior vein, is rotate your clamp, and now you're almost done. You're in the home stretch, and you'll take it, look back and see where your methylene blue is, and cross the coronary sinus with the clamp. It's absolutely safe to ablate the coronary sinus with the bipolar clamps. We've looked at that.
It's actually necessary.
It's necessary and safe. It is. We've done it with the bipolar clamps in 5 chronic animals, and we now have experience in over close to 500 patients and never seen a complication. If you remember, in our cut and sew maze experience, we would take the cryo and ablate the coronary sinus full thickness and freeze it, And that also has never been shown to cause a complication. So the coronary sinus, I always tell people, is probably the most resilient, one of the most resilient venous structures in the body, and it certainly can take a beating. So, and it's very important in terms of if you want to get the left atrial isthmus, that is, take a line of block from your pulmonary vein island to the mitral annulus, which is extraordinarily important in preventing late left atrial flutters. You have to ablate the coronary sinus in full thickness in line with your left atrial wall ablation to the mitral annulus. Now, when you do the clamp, you can often and usually can get across the coronary sinus, but it's almost impossible to get all the way to the mitral annulus because the clamp will keep slipping off the AV groove, which is quite thick. So you end up usually with about a 1 centimeter endocardial gap. And again, that we've done effectively with the pens and have had very good results with that. And we've also used a reusable cryo, and in that situation we use a 15 millimeter bell-shaped cryo probe cooled to minus 60 degrees centigrade for 3 minutes. If we have any doubt of the ablation across the coronary sinus, and usually we'll often add another cryoablation across the epicardial surface of the coronary sinus just to make sure we've ablated the coronary sinus. It's interesting that even in the cut and sew maze, one of the most common areas of failure was reinitiation of conduction across the coronary sinus, despite having a very full thickness cryo lesion. So we think that might be an area that, you know, for some reason seems to, you get regrowth of the muscle bundles. And, you know, it's just an area that we do focus on, and I think if you want to get high success rates, you need to. So that finishes the maze procedure.
Fantastic. I just had a few tiny other little sort of questions. I know you've just recently done a hybrid procedure. Somebody asked me, you've got to ask him, what's the Cox Maze 5 going to be? It's going to be hybrid, isn't it?
Yeah, I think that's where I think, you know, we're going. I think the hybrid is an exciting area, but one that's still there. You know, I would have to say that you really need to have a dedicated center. It should be done under IRB approval at this time because it is really investigational, and we just don't know how well that's going to work. We're planning on doing a randomized trial where we'd actually look at what we add. We would take a bunch of patients, and actually the patient you presented to me is the perfect patient. So we're looking at long-standing persistent AFib and an atrial diameter of greater than 4.5 centimeters. This is a group that they do very poorly in the EP lab with, and we're going to randomize them to a hybrid versus a single catheter ablation, and we're going to follow the exact same protocol in terms of ablation, except that with the hybrid we'll be able to do epicardial ablation while the catheter patients will just have endocardial ablation. So I think that would be would provide some really good evidence toward what we can bring as an advantage from our what's now a long experience with epicardial ablation.
Right, well, that sounds absolutely fascinating. I think we'll leave it there, but that's been an amazing insight, and I can't wait to talk to you again and find out the results of these things. And so from me, Joel Dunning, and from CTS Net, I'd just like to say thank you very much for the interview. Thank you very much.
Thanks, Joel.
Thanks a lot.